We have many patients that have pain in the back or their leg, and that can be from two sources. There's two things that can cause the exact same distribution of pain, either the hip joint or the nerves that are exiting the spine and running into that part of the body. There's four ways that we can determine what the source of the pain is. Medicines treat the symptom. We're trying to treat the source. So there's the location of pain. There's the results of imaging tests. There's physical exam. And most important is the modifying factors of when the pain is better or worse. When the hip is the source of the pain, it's skeletal. So they get very prominent groin pain, usually when they're walking, and little, if any, pain when they're sitting. And there's exams to try to stress the joint. When it's neurologic, people universally have pain in their buttock where there's a bundle of nerves there. And even though the pain is there, the source of the pain is central and it often runs down into the leg. But buttock pain with this condition of spinal stenosis is pretty common. So if people have the full distribution of pain, then each of the nerves that exits the spine has certain locations in the leg. L2 and L3 run down the front of the thigh to the knee, L4 down the side of the calf, and L5 goes down the top of the foot to the big toe, and the S1 nerve runs to the sole of the foot or the side of the foot. So sometimes we know which nerve it is by the location of the pain or by the imaging tests. There's two things that contribute to the spinal stenosis. There's some underlying degeneration that has taken years or decades to develop. And then at the time that the pain starts, often they've done something new, usually physical or strenuous, that has developed an episode of inflammation. And then the narrowing that's always been there with little or no symptoms and the inflammation, which is new, then together causes the pain. So there isn't any test that can detect inflammation. So the first thing we do is the treatments that we know is needed to resolve the inflammation, and that's injections under X-ray guidance. So there's two tests that we get for spinal stenosis, MRIs or imaging studies where we can see the structure of the spinal cord and the nerves. And the other test is an electrodiagnostics or an EMG. We do the EMGs when we want to do a procedure of nerve root injections, and we need to know which nerve it is. And the way that electrodiagnostic test works is whatever nerves are causing the pain, also the nerves go to certain muscles in the leg. So when the nerves are affected, the muscles develop cellular changes that can be detected with electrodes. We use electrodes in selected muscles in the leg. And when we see which muscles have these changes, then we have a target for a very specific treatment of placing medicines under X-ray guidance directly into the areas where the nerves are that are causing the pain. So that's a nerve root injection. That's one of two types of shots that we do. The other type is epidural steroids, where the medicine is placed more centrally where the nerves originate rather than on the side where they exit. When we do the central epidurals, the medicines distribute to both sides and multiple levels. People are dramatically better after the initial treatment as the inflammation is reduced. But when the inflammation episodes are well established and been present for long periods, it takes typically two treatments to get rid of all of the inflammation and often all of the pain. Most people come back after the initial treatment and the pain is no longer constant, becomes intermittent, and at least half gone. If we get that usual result, then the second injection is the same as the first one. If they get an initial result that's less than that, we would do the other type of shot. Then once people are healed, see, all of this started with the episode of inflammation, we can resolve the inflammation with these interventional treatments. So once the inflammation is gone and the pain is better or often gone, then they would never have pain again unless they get a new episode of inflammation, which might be years or never, and we have specific prevention strategies for that.